This is the first of a series of webinars, and I am delighted to be moderating it. I am Melanie Piccolo, PAT's Integrated Maternal and Child Health and Development Program Manager in Mozambique. I oversee a portfolio of projects in maternal, newborn, and child health and nutrition, early childhood development, immunization, malaria, and other domains of public health. I'd love for you to add in the chat where you are joining us from and which entities you are representing. I can see we have representatives from the government, development partners, donors, and members of the civil society from all over the world. I want to thank you all for being here and for all that you do for our women, children, and communities in general throughout Africa and beyond. We hope that throughout this meeting, we can network, exchange knowledge, and learn from others in advancing MNCH advocacy at the country, regional, and global level. For those of you who are less familiar with PATH, we are a global team dedicated to achieving health equity so that all people and communities can thrive. Together, we are driving public health solutions that meet the most pressing needs of families, communities, and countries. Although PAT's global team works in 70 countries around the world, our advocacy and policy portfolio focuses primarily on the African continent. As advocates for women, children, and adolescents, we all know that progress towards global goals to save the lives of women and children is lagging. Thank you for joining us in elevating this agenda again. So in terms of ground rules, I hope we shall all remain muted unless called upon to speak. I request us all to remain actively engaged in the conversation. Please feel free to use the chat function so that we work towards a joint advocacy vision for this work. My colleagues will be monitoring your questions in the chat and will be saving time at the end to respond. We also have an interactive session where we shall be able to dive deeper into the conversation very shortly. At this point, allow me to introduce Esther Nasiki, who is PAT's Global MNCH and Immunization Advocacy Lead. She's based in Uganda and is a seasoned advocate for the health rights of women, children, and adolescents, with over 15 years of experience in public health policy, gender, stakeholder engagement, and strategic advocacy, including collaborative work with alliances at grassroots, national, regional, and international levels. Esther, you are welcome to set the scene and frame the conversation for us today.
Thank you. Thank you so much, Melanie, for the warm introduction. Good afternoon, good morning, colleagues from across the world. Thank you so much for joining us today for this first meeting in this Africa Regional MNCH Advocacy Dialogue Series. I know as advocates, some of us are wondering, why are we meeting today? I'll tell you why, but first, I want to provide a bit of framing for this conversation. In 2014, the Every Newborn Action Plan was endorsed by more than 194 WHO member states, and it provided a roadmap to eliminate preventable neonatal mortality, stillbirths, and contribute to reducing maternal mortality and morbidity. In 2015, which is the year that followed, the strategies for ending preventable maternal mortality were released, and they outlined the targets to achieve the Sustainable Development Goals and strategies to strengthen maternal health programs. The Every Newborn Action Plan and the EPMM aligned their targets, they established a joint population coverage targets. And these include, this is what we refer to as the 90-90-80-80 targets. And if you're new to that, I would simply tell you that it means we are targeting 90% of pregnant women receiving at least 4 ANC visits, 90% of women giving birth should be with a skilled health worker present, and 80% of new mothers and babies receiving postnatal care within 2 days of birth. But also, we set district level targets. So looking at the subnational targets as well, the plans, give us the target of 80% of districts to achieve at least 70% in terms of ANC coverage, 80% in terms of coverage for skilled birth attendants, and 60% for postnatal care within 2 days of birth. Last year was a historical year because we held the International Maternal Newborn Health Conference in May 2023 in South Africa, and this was organized by Align MNCH. And during this conference, we had the opportunity to look at the solutions for improving maternal and newborn health and preventing stillbirths. But also, the conference provided a strategic opportunity for countries to reposition maternal and newborn health and agree on the steps towards regaining lost ground, because we understood that some of the indicators and the most important indicators were stagnating. We are aware that so many countries, at least about 29 countries, have drafted and submitted their in-app EPMM country acceleration plans with the leadership of the Ministries of Health. Why are we here today? The question is, as advocates, how are we contributing to these acceleration plans? Because we know that to end preventable mortality for women and babies and children at the national level, at the community level, it is going to call for very strong advocacy, to support resource mobilization, to support strong policies, to mobilize communities, and definitely drive demand for services and products at that subnational level, at the national level, but we also know that at the global level, it remains important. So PATH is partnering with like-minded organizations in the region, and these include, civil society partners, but also normative agencies to convene these quarterly meetings to bring partners, advocacy partners together to drive the agenda for MNCH advocacy, to share progress on commitments, share experiences and lessons to ensure that the acceleration plans that have been set at country level are actually realized. So in terms of the specific objectives for this session, we are looking at fostering dissemination of new evidence. We know that some of the partners have not been able to look at the new evidence that has been provided, which was actually launched during the conference that I just mentioned in South Africa. But we are also looking at identifying opportunities and strengthening linkages and collaboration among stakeholders to advance MNCH advocacy in the region. We also want to look at the lessons learned from the past MNCH advocacy initiatives, because we know that this is not the beginning. Work has already been progressing, but then how do we accelerate momentum? We need to learn from the past, and we'll be hearing some of those lessons today. But also as we look at the past, we need to understand what the challenges are and the barriers towards ensuring effective advocacy. And finally, once you've understood the challenges, then we need to come together and build strong strategies to move forward, to advance the MNCH agenda. So our hope today is that when we hear some of the experiences from the countries, when we hear some of the experiences at the global level, and also the plans that are being shaped at the moment, we will come together to have stronger voices and ensure that we are building, a strong advocacy movement and, rejuvenating momentum to advance the MNCH targets in our countries, but also in our region. So with that, I hope you understand why we are gathered today, and I hope you will be contributing to this conversation, because the agenda is bigger than all of us, but if we unite, we are able to advance. So thank you so much for joining, and we look forward to hearing your voices and your thoughts and ideas. Thank you so much. Over to you, Melanie.
Thank you so much, Esther, for setting the scene so well for this conversation today. To meet these objectives, we truly want to make this webinar as interactive as possible. So we're going to kick off with a Menti session. On your gadget, please go to menti.com and fill in the code that we will be displaying in a minute. Also, if Kelly can put the code on the chat, please. You can see the code here as well as a QR code. So please log into the platform menti.com. Either enter the code or use the QR code to get there. So would like to just read your thoughts around a few questions that we'll put up on the slides and that you should be seeing now. And for each of these questions, please enter as many responses as you'd like, just so we start this conversation, that we hear from you too, and that we then progress into hearing from others that are very active in MNCH advocacy. So, love to hear from you. What do you think needs to be done to advance advocacy for MNCH at country level? So please share your thoughts. I can see we have a few responses coming in already. Increased collaboration, engaging subnational partners, building investment cases, engage parents, building stronger coalitions for MNCH, more government buy-in, agree upon and pull through key holistic messages, important. CSO and advocates need to have a seat at the table at technical national level working groups to link evidence with the advocacy agenda. So we're hearing evidence, investment cases, bringing partners together into strong coalitions, engaging parents and subnational partners. That's great. So we'll transition into our next question. Now, let's think about the regional and global level. What can we do to advance advocacy at those higher levels, regional, global levels? Thank you for those who have submitted responses so far. We'd love to hear from more of you. We're talking about cohesive approaches from subnational and national levels. What else do you think we can do to advance this agenda at regional and global level? I can see a hand up from Feisa. I'm not sure if you want to come in or if that's just to say hi. Find key advocates who can speak and influence. Absolutely important to have champions. Strengthen coalitions once more. Bottom-up cohesive approach. I'm loving some of these responses. Keep messages simple and at high level, powerful messages as well, having ambassadors for the cause. Multiple sector engagement and partnerships. That's so key because many of the issues that affect MNCH outcomes don't depend on the health sector alone. Clear priorities, not trying to do it all at once. And I'm sure there are more towards the bottom that I'm not seeing yet, but this is a great start to the conversation. So maybe we can transition to the next question as well. As advocates, what support do you need to further the advocacy agenda around maternal, newborn, and child health across all levels, country, regional, global? So what do you feel it's missing that you would love to have more in order to advance this agenda? Funding. That's a big one. I'm sure we all feel the same. Data. Indeed. More cross-learning. Greater focus on evidence-based and cost-effectiveness arguments. That's very much linked to the initial responses on investment cases and evidence-based advocacy. Subnational data. Great. Adequate information on the actual needs for maternal and newborn health. Digital platforms to engage with like-minded advocates. Love that. We need to digitize advocacy. global coordinating body missing for maternal, newborn, and child health. Thank you so much for those very relevant, very relevant responses. And it really helps to set the scene for the conversation that we're gonna have next and hear from our panelists. So we'll now transition to our moderated panel session. And we are going to hear from three very knowledgeable panelists in the field of maternal, newborn, child health advocacy, including Angela Nguku, who's the founder and executive director of the White Ribbon Alliance, Kenya. She's a passionate reproductive, maternal, newborn, and adolescent health champion. Angela's career spans over 15 years of dedicated work towards ending preventable maternal and newborn deaths globally and amplifying the voices of marginalized and vulnerable populations in Kenya, throughout Africa, and globally. We also will have with us today Jackie Katana. She's a certified project management professional, health expert, and sexual reproductive health trained advocate. She has 20 years experience in formulating, implementing, and managing public health programs, working with bilateral organizations, UN agencies, foundations, NGOs, and FBOs. As a trained health advocate, she has extensive experience in health policy at national and international level. Jackie is the founder and executive director of the Faith for Family Health Initiative through FHI, an interfaith NGO in Uganda. She is the Uganda MNCH and Healthy Aging CSO platform chairperson and represents CSOs on the Health Policy Advisory Committee of the Uganda Ministry of Health. And also, she is the Global Financing Facility Investors Group CSO representative at the global level. Thank you for joining us today, Jackie. We also have with us Benedict Walter. She's a senior advocacy consultant in the Department of Maternal, Newborn, Child, and Adolescent Health and Aging at the World Health Organization. Benedict has over 25 years of experience in communication and advocacy for development programs at country and global level. So I will now invite our first speaker, Angela. You have a number of years in MNCH advocacy. And I would love to hear from you, Angela. What do you see as potential opportunities for partnership and synergy among stakeholders at country level?
Thank you so much. And I'm really glad to be here. I hope I'm audible enough. I think one of the things that you didn't mention is that besides the organization I work with, it's a movement. White Ribbon Alliance movement has been advancing reproductive maternal newborn health advocacy for the last 25 years. And this year we are celebrating our 25th year. Having decolonized the movement, claimed our power as a local-led movement. And I currently co-chair the movement with my colleague Parajita based in India, because we realize that at the end of the day, it's the wearer of the shoe who knows where it pinches most. And as long as MNH continues haunting the people in Asia and Africa and being led from the north or from minority world, then we are not getting anywhere. And so one of the greatest opportunities I see in this space is acknowledging that at the end of the day, whoever leads, whoever is suffering is the one who has the solutions. We know what the solutions are, and we know what we know the problems are, and we know what the solutions are. And I think one of the things that has failed us, and I say this as I come to the opportunities, let me start with the challenges, is the fact that the MNH has been looked at as a specific group for specific people. I want to challenge everyone who's attending here, advocate, whether you're a donor, whether you're everything. If you look at globally, looking at the key bodies that are driving the MNH agenda, majority are led from the minority world. And I'm not afraid to say that. And yet at the end of the day, most of this, what is seen is really theoretical. The people who have lived the realities from where the issues are, the highest burden of maternal and newborn health is in sub-Saharan Africa and Southeast Asia. You will rarely find most of the people in those spaces. Let me tell you the rest of the challenges, and then I'll come to the opportunities and the things that I feel are really present. I speak like this, having been a steering committee member of Align MNH, having been part of the APMM INAP management team last year, and having been part of the PPH steering committee body, and I still sit in different spaces today. Having been at an MNH conference in South Africa last year, from the report that was shared, it was clear that at the end of the day, there are key gaps that are really glaring at us. And once we address that, we will be able to really connect the dots and get it right. One of the things that I'll talk about today is the place of community engagement. Who is community? For me, community is the people, 80% of the real experts that I keep on talking about in whatever space I find myself. I keep saying, yes, I'm a graduate midwife. I have worked in the global development space for the last 17 years. I know only what I know as a midwife, as a mother myself also, but also having interacted in the movement here in Kenya and globally with the rest of the people, the women and girls that we work with and for every day. And having led the What Women Want campaign in Kenya, in Africa, and beyond. And so for me, I look at it, I'm giving this from that perspective. So for me, community has been the missing link and other actors. Why I say that is because MNH, we all know that at the end of the day, MNH is multisectoral. But how are we addressing the issues? We know the causes of maternal mortality. We know the causes of newborn mortality. We know that quality of care is the missing link. And women and girls have told us what quality of care means to them. But we have chosen to ignore and still continue chasing the issues that we think is what is needed by the people that are still dying. In the meantime, we are still losing 830 women every day, every single moment. Every day, women are still dying because we've decided, let them come. We have the reports. We are not going to bother with it. We are going to continue with what we know. Let me tell you the other thing that is ailing us and where the opportunities are. We are still talking at the boardrooms. We are still organizing webinars. I'm not saying it's a bad thing to have this webinar, but I've been in so many of them talking about the same things. We have refused to move funding beyond the boardrooms. We have refused to move funding beyond the processes, beyond the documents, to actioning it. If I remember very well, in South Africa, we decided that an MNH movement was birthed, and we were supposed to be driving the issues from Cape Town to localize the MNH agenda to ensure that everybody is part and parcel of this. And so we are still talking to each other, to one another in different spaces and the like. So we need to localize not just the MNH conversations, but the commitments, but also the investments. We are still investing at the top, at the global. We are yet to move to the regional. At the country level, if I talk about a specific issue like EPMM INAP, the action plans are still being done at the country level. Even in a country like Kenya, we are still to move beyond the country level, the MOH, to the counties where it is localized. I work in these counties, and I can tell you that nobody understands what EPMM INAP is at that level. That is where the women are dying and the newborns. So for me, I see there's an opportunity for grassroots organizing. We need to embrace the strengths of each other because we have tried and it's not working. So what do we need to do? We need to really dismantle the structures that exist and look at, introspect deeply what are the issues and hold ourselves accountable to realizing that we have an opportunity. 2025, when we go back to MNH, to another MNH conference, we need to come back and say, what did we win? We have an opportunity, we have 2 years. What exactly have we been able to do? The other thing that I want to say today is that we need to drop. Yes. Thank
you so much for your passion. I love it. I just want to ask you to please slow your intervention a little bit so the interpreters can also transcribe what's being
Sorry, I think I get very passionate about the issue, but I'm
I know.
I was wondering when Esther was saying she speaks fast, and I was like, Esther, are you sure? Anyway, the other thing is that we need to bring all actors on the table. We have an opportunity. We know who the actors are. We know the community is an actor. We know the midwives are an actor. We know that the doctors, we know that the private sector is an actor. We know that the different aspects of it, because as I said earlier, MNH is multisectoral. How are we ensuring that at the end of the day, we are addressing maternal newborn health from addressing the referral system, through addressing the road transport network, we are addressing maternal anemia through addressing agriculture nutrition. We are addressing insecurity through the administrative aspects of security that we need to deal with in our countries and the like. we also need to drop the talk. We need to drop the egos and the logos. We are so much into, it is path directed, it is white ribbon directed, it is WHO directed. At the end of the day, women don't care about those issues. At the end of the day, women care about, I want my needs respected and addressed to. It is not about who has actually given the money. It is not about who has actually given their name. We need to drop all those things and actually realize at the end of the day, we stop siloing women, we stop deciding for women, and we just come together and collaborate. At the end of the day, we need to be able to drop the competition. We are competing to show who has won. But at the end of the day, we are losing more women. So for me, I feel like the opportunities that we already have within ourselves, that we need to embrace the moments, the movement making that started in South Africa a year ago almost. We need to really agitate that and bring more people. We need to localize it. We need to bring more actors who at the end of the day are going to work to ensure at the end of the day, we can be able to embrace it all, bring it all together. But most importantly, we need trust-based funding. What I have seen happening is, if it is not being given, if a donor in the West, in the minority world does not give to an organization based there, that money cannot reach the other places where the women need it because we don't trust them or they don't have the capacity. We just need to agree that that is just the whole aspect of, we need to decolonize how we fund MNH. We need to decolonize who leads MNH. We need to trust based the people, because we have been pushing for this and people are doing great things. I've seen self-help groups, women groups doing so much, youth groups doing so much, midwives doing so much. Can we just trust that and invest in them? We need to trust them and fund them. And at the end of the day, we need to ensure that we use both data, the quantitative and the qualitative. I keep saying this, behind the numbers are lived realities and experiences. Are we listening to these women? Are we hearing what they're telling us? Are we reaching all of them? They are not homogeneous, they're heterogeneous. Are we really taking advantage of that? And how do we do that? We have people spread all over the place working on different aspects to address women. We need to be able to expand our tentacles and reach all these people and bring them together. And at the end of the day, we need to really embrace the opportunity and run with it. The time is now. Thank you.
Thank you. Thank you so much, Angela. Can you tell us a little bit more about how the White Ribbon Alliance is actually organized and how you work with different civil society partners to contribute to the Every Newborn Action Plan and ending preventable maternal mortality agenda, and how also you link with the Ministry of Health in Kenya?
I think for me, our White Ribbon Alliance, as I said earlier, it's a movement, it's a network. We are not only health related. We work with different people, from individuals, anyone who cares to address MNH across different places. So we bring them together into powerful action networks across the different countries that we work. And that is how we come together to amplify, to elevate, to contribute to the MNH agenda from the grassroots. That is simple. And we've done this for so many, we've contributed to so many bodies of knowledge in different ways. We led the What Women Want campaign across board. We led the development of the Respectful Maternity and Newborn Charter that has been adopted globally. We have done so many weeks. We use advocacy. We use advocacy for accountability using different approaches, including citizen journalism, including so many approaches. They are online, our power tools, our power models, and the like. And as I said earlier, we are now localized. We have the hub in Kenya, the hub in Asia. We have different ways that you can be able to connect the different members. And we are not just in the different alliances, the 15 alliances across board. Our members are across board, but these are the different alliances that are already structured, but we work with people from across the different parts of the world. So that is it. And so in different places in our different countries where we work, we link with the MNH and we bring in the advocacy, the grassroots advocacy organizing component across the different places where we find ourselves. Back to you.
Thank you. Thank you so much, Angela. As I said, it's lovely to hear your passion. I hope that our French-speaking and Portuguese-speaking colleagues were able to hear that too. And that, you know, even if the translation was very rapidly flowing, that you hear the passion in Angela's voice. And I heard a lot about localizing the advocacy agenda, bringing the funding to where the needs are, because we're really in the field where we're feeling what those challenges are, and designing solutions with communities in mind, with communities involved in the design, is going to lead us to better results. We know the solutions, but we need to decolonize it, localize it, and fund it based on trust. Thanks so much, Angela. We'll now transition to hear a little bit more also from Jackie Katana. But before we do, I want to remind you to please add your questions on the chat. We will be having time towards the end of the panel to be able to respond to them. So please feel free to, as you hear and as thoughts and questions come to mind, please write them in the chat. So Jackie, I'd like to invite you to now share with us. As the CSO Global Financing Facility Investors Group representative, what do you see now as opportunities for linking advocacy from the national level, from your experience in Uganda, to the global level?
Thank you so much, Melanie, for a very humbling introduction. That sounded a big profile, and I'll be a little humble today. So Esther, don't laugh when I'm humble, and I'm always. Yeah, so linking advocacy from national to the global level. I'll tweak it a little bit, go back to where my sister stopped. I'll add a little bit of picking it from the community. Because when we talk about advocacy, it's very linked to accountability and social accountability, which monitors implementation of most of these interventions, implementation of, for example, the RAMCA +N, sharpen plan, indicators and issues around EPPN and INAP. And that happens at the community. So bringing it from the ground, from the citizens' voices, from the last mile. And then those issues are able now to inform the national engagements. And that's what my sister called boardroom, you know, where we are now looking at what are those issues that are affecting implementation on ground. Why are people not accessing services? Why are commodities not available? Why are services not available? Why are they not accessible? Why are they not being utilized? And then those ones now bring us to engaging with the decision makers to hold them accountable through our advocacy engagements. And in Uganda, we've transitioned, which I know that many countries have, to more of smart advocacy, engaging to the deepest with the evidence. That evidence is generated from the ground, just like I shared, so that it's not an allegation, it's not what you read in the newspapers, it's not what you had people discuss as you passed by. And that evidence helps us now to develop tools that are where we engage either through consultations, dialogues, media advocacy, and many channels. So after linking that, very, very important that we also do it in a much more collaborative way. And that's in the mentee, I like they've answered part of it where they talked about coalition. Because we cannot act in isolation, whereas we are addressing issues of INAP and EPPN and the entire MNCH. There are many actors, and actually there are many coalitions, there are many platforms, there are bigger ones, umbrella like RAMNAC, but there are also those small ones like the technical working groups, the clusters, the task forces. How do we bring them together and agree on an action plan? And I really appreciate the newborn accelerated plan, which brings all of us together to be able to put our voices. And those voices now, again, I'll go back to the GFF approach. All that is informed by what we call the CSO engagement strategy, clear articulating from advocacy, accountability, issues of financing that my sister talked about, domestic sustainable financing, harmonizing and aligning resources. We know that we also have that issues, like now we are dealing with the issues of the global health initiatives. GFF is moving in this direction, Gov is moving in this direction, Global Fund. So how do we align bilaterals, UN agencies, and then we also now get to our government to start looking at what we are doing. Again, I'll be able to say we are proud as CSOs in Uganda. We've pushed to really squeeze the hard stone and rock. and we've been able to get some resources. Now we have 80% in the new budget for health. And the good news is that most of it is for procurement of RAMNA commodities. And the budget for those commodities has risen from 22 billion Uganda shillings to 29, including funds for operationalization, which has caused stockouts, being able now to equip the national medical stores to distribute up to the last mile. So in a way, to us, that's a national engagement that looks at how do you connect the national to the community, community back to national. Then you go back to the same engagement frameworks. For example, now under the JFF, we have the spaces like the investors group. This is a governance body bringing all donors, private sector, governments to engage. And as CSOs, we are there to amplify those issues. You're giving us funds. And in that same house, we have Gavi, we have foundations like Bill and Melinda Gates, we have Global Fund, and we are holding them accountable to say, why are we not seeing improvement in these countries? So from that, then you find that also Gavi has a space, Global Fund has a space, PEPFAR has a space, and we are now creating, for example, you'll find that if you are CSO representative, then you're seconded to again representing all those and bring those issues. So as CSOs, you're again consolidating those issues. And that's why I'm saying linking again will require us to work together as champions in different spaces. How do we share this knowledge? And I'm glad that this webinar is here. Otherwise, I would be seated on my desk and I'm trying to see, but otherwise now I'm sharing, and also the mentee people have already shared evidence generation. I already talked about it. I've already talked about strengthening partnerships and networks. What are those bigger events that are happening? The conference on newborn, maternal and child health, ICPD, ICF, World Health Assembly. What are we doing? How are we coordinated to amplify those issues so that it's not part year one, but we are moving? If it's enough CSOs, we are going that way. EPPN, where are the gaps? Because you find some countries are doing well and others are not really taking long. They're taking long to recover. The JFF annual report 2022-2023 appreciates that there is a little bit of bouncing back from the COVID relapse. So the indicators are improving. Though in Uganda, we are celebrating CSOs, we are now really celebrating. We're able to hit from 336 out of 100 live births on maternal health to 189. And then infant mortality rate from 43 to 34. But again, we are not yet there. And this brings me to the issue why we need to speak the same language. Because we have issues of equity and inequalities. One country is celebrating, another one is really suffering, especially a majority of those are in sub-Saharan Africa. So you find that there is one that is really doing. So if we are collaborating as CSOs, whereas Uganda needs resources, needs capacity building of CSOs and the leadership, how can we support the rest at this bigger picture, the global level? Because the issues we're addressing are beyond our particular community, are beyond our country, but now we are looking at one global village. How can we make sure that those resources trickle back? And that's why my sister, the previous speaker, was talking about localization. Localization will help to address some of those iniquities. Why sub-Saharan Africa? If I was able to read for you briefly the snapshot of what is in the snapshot of what is in the JFF report, it actually says that it's very unfortunate that majority of the rollback are going to be in sub-Saharan Africa. And those JFF support 36 countries, and those 35, most of them are affected by that. So that when you see that the increment, the improvement is very minimal. I'll give you an example. We are here celebrating about infant mortality rate, but the report last year, 2023 in Uganda shows that even when you are celebrating a 3% plus increment per year or improvement in infant mortality rate, we have neonatal death at OPD in a very alarming way is the most leading cause of death in newborn in Uganda. And you know what is causing it? Sepsis. That's infection control. It's very simple. It's not commodities. It's not a resuscitation, newborn resuscitation devices, just infection control. So those are some of the areas we need to continue to iron out if we are able to move ahead. Mobilize resources together, strengthen our leadership, link our work from ground to global level, leverage on what is already produced tools, work as champions, make sure that we advocate towards coordinated response, where we have donors, CSOs, governments working together, and very, very important, bilaterals, UN agencies, the Global Health Initiatives, Gavi, Global Fund, GFF, they need to align their planning, they need to align their monitoring, they need to make sure that they speak one language, aligned to one health approach. Thank you.
Thank you so much, Jackie. I'd love to hear just a bit more about how do you bring those successes from Uganda through these global platforms in which you are integrated to reset the balance a little bit and increase the equity. How do we bring some of those lessons, some of those successes from Uganda on budget allocation, on indicator improvements, and how do we influence the global discourse so that those countries that are lagging behind a little bit more then have investment, then have efforts to bring them to the same level as countries as Uganda?
Melanie, the first answer is what you've done. Spaces like this webinar is to share experience, because if someone knows that something is happening in one country, then we are able to learn how they've been able. So one is to, as I said, coordinated and collaborative joint response of the CSOs. For example, if we have champions and different leaders at the global level, how are we speaking to each other? How are we sharing this information? How are we sharing the tools that have worked? So that we are able, so again, in the mentee, someone talked about the cross-learning. How do we learn from each other? And that's very, very important. And what of us have learned over time is that as advocates, depending on which level you are, when I'm in Uganda, I'll speak, when I'm a chair for RAMNAC, I'll speak for Uganda like there's no any other country. But when we go as global champions, I'm looking at all countries, and we are looking at now, how do we move together? Because these issues, at the end of the day, when we fail together. Now, I'll give you another example that was highlighted in the GFF annual report. In the last year, 2022-2023, 100 million mothers were able to access to have 4 antenatal visits or more. And again, they were able to secure 130 million safe birth. So when you look at it, it's big. But remember our target of 230 million by 2030. That effort is for all of us. It's for CSOs, it's for all development partners, for community, it's for academia, it's for all of us. So the reason why you should not be comfortable and say, oh, for us as a country, we are doing very well. The target is at global level. And eventually, if you're not addressed, the resource balance and the inequities will affect all of us. Thank you.
Yeah, you just mentioned how big of a gap we still have, that we have to, again, come together through this platform to elevate the agenda. Could you share just, like for you, what was the key driver in Uganda of the increased budget allocation for MNH and the improved outcomes that you're seeing there, the increase in some of those key indicators that you're tracking? What was for you, the critical ingredient that was in the mix that really led to that sensitization, that change?
One of the game changers, traditionally I'm a programmer, but what attracted me to advocacy is how advocates were doing work in Uganda in 2014. When I watched, I said, this is the space to be. And one of those game changers is we work together as a team. And we pull resources, we pull knowledge. And actually, right now, we are the most underfunded, because of our context issues. But one will bring whatever they have. Part will give us a boardroom. Another one will give us water. Another one will give us a notebook. And we'll move. Yeah. The other one is consistency. We keep the same language because actually, most of it came from the capacity building. Most of us were trained as advocates, smart advocates. So we know how to speak the same language consistently. Like now, the national health insurance, we stayed on. It doesn't matter how long. We are still talking until we get it. So consistency, capacity building, working together as CSOs, joint voice, irrespective of whether this is a project where you have indicators. For us, we need to achieve together, then you put what you report in your project. And that's a game changer to us, especially in the reproductive space. We have many underlying questions, but when we move one as MCH, as RAMNAC, the language is one. And whoever has knowledge will share. And that has helped us. Even, as I said, right now we are really constrained, apart from a few support from JFA, from individual organizations like PATH and others, but we still pull whatever we have, whether it means sitting under a tree, we'll still draw our agenda and we engage. And that has made us adapting to the government. Actually, the decision makers now are on our side. They're our friends, they're allies. We know, can they open? And that's why we are almost, the CSOs are represented in all spaces. And whatever they can do, they even ask, oh, CSOs, what can we do? Now this policy, come and help us. How can we move it? One of the key example I'll give you, I was even laughing when we are joining, we just developed and approved the Sharpen Plan, RAMNAC Sharpen Plan 2. And the Ministry of Health itself, with the support of PATH and other partners, they are developing an advocacy toolkit. In my heart, like, how do you develop a tool that is going to shoot you? But that appreciates that without advocacy, they are not going to achieve implementation of this Sharpen Plan. So kind of we've got them on our side, and they know that they need us as colleagues. They have understood our language, but very important, we've been smart in our engagement. Evidence, consultation, understanding the space, and moving together as a troop. Thank you.
Thank you, Jackie. Thank you so much. I think you really reinforced the message from Angela as well, that, you know, we need to leave the logos behind and come together as one for the same cause that we're all working for. So thank you so much again for remarking that. It sounds to me like the chat function is not working, and we apologize for that. Please do use the Q&A function to share your comments and your questions, and we'll make sure to address them at the end of the panel. I'd like to now introduce our final panelist, Benedict. Please, could you share with us, and as you reflect on what Angela and Jackie just shared, what do you see as the key strategies to ensure linkages for stronger MNCH advocacy from the country, regional to the global level? Over to you, Benedict.
Thank you very much, and thank you to Angela and Jackie before this intervention. I think they've covered absolutely everything that is critical to make this happen. And the two main points I keep hearing, and I keep seeing also in the Menti responses from this group, is one, collaborate. And we all say that, but I think Angela really drove it home when she said it's collaborating is also stopping competing for attention, competing from the same pot of money, competing in our own small health world, and really going, you know, multi-sector, multi-stakeholder, broadening the horizon, really. So it's not just about working together, but it's really about breaching this barrier. That is absolutely key. And even when we all talk about partnership and working together, it's a bigger issue on how we think beyond MNH sometimes, or within the health sector, linking to other part of the health sector, such as women's health or reproductive health, but also beyond the health sector with nutrition, early child development, gender equality, climate change, and all these other things where you cannot put these women and babies in a silo and ignore everything else that's related and deeply affecting this population. So that's the first thing. The second thing, which is also very clear, and I think nobody can argue against this, is that we need to decolonize and localize, and really, you know, center all the work with the organization and the group that have the legitimacy, the access, and the expertise to actually drive changes, and that is critical. And so, as some of the people on this call know, there is a coalition being built or building itself to develop an MNH advocacy strategy. And the reason I say coalition is because even though it's led by WHO, it's really not a WHO strategy, not least because a key component of this strategy is to center the work of CSOs. This is not something the WHO does or does alone. It really requires a whole system in place to galvanize many, many partners. So this is why I'm particularly excited about today's webinar, because talking with you and hearing your thought about this and how this is not just a piece of paper, but actually the necessity to engage the CSO in their role, in your role, to elevate issues, also to provide depth and expertise and knowledge to decision maker when it's come to rolling out services for maternal and newborn health, to elevate the voice of the affected populations, and also to hold decision makers accountable. This is something that needs to happen in practice and at all levels. So at the national level, obviously, as leaders, but also at the regional level with events such as today, where we share problems, learning, difficulties, opportunity to advocate together, and then at the global level, because the global level only makes sense if it's informed by this. We know from the INAP EPMM report that I think it's Angela who mentioned, or maybe, no, it was Angela indeed. We know what needs to happen. So we look at the very dismal statistic on why it, maternal newborn death doesn't reduce fast enough. And we do absolutely know what the gaps are and what needs to change between right now and 2030. So, raising the bar. So if we want more results, we need more investment. We need more political willingness to support this. We also need to invest in quality of care at all levels for everyone. We need to go local. So a lot of time, and many of these acceleration plans that you mentioned are talking about this. It's all very good when you have a Ministry of Health leading it, and it's very necessary. But then there's also the discussion about what does it mean at subnational level in countries with a huge disparity in terms of access to care and quality of care. We need to engage at the very beginning, the women, the family, the communities, the parents group, if we want this plan to actually reflect the needs of the population they're meant to serve and to support. And we also need to adapt the data system. So we know these are the 5 things that need to change to really see a change and an increase or a decrease in the maternal newborn death, an increase in the reduction in a way. And that is acquired. So that strategy, as I said, is a coalition effort. You might wonder, what does it add to all the strategy we have in place? I think that's really it. It's the fact that it's 40 organizations trying to work together based on what already exists, on the coalition, the advocate coalition at country level and subnational level that already have done incredible work, and building around this a partnership to support this. And we've heard, we've done, the consultation has taken many steps and many circles of consultation. But the latest one was last week in Bangkok. We had a INAP EPMM regional consultation. So it was for Asia Pacific. There is another one planned in June for Southern and Eastern Africa, and there is another one toward the end of the year for Western Africa. And what my colleague were there reported, I wasn't there myself, was saying that it was really incredibly interesting to hear that of the coalition they're already doing it. So it's not a matter of implementing the will, which we knew, but really capitalizing on their work, enabling their work, funding their work to make it happen. So how do you really make sure that it's the best possible environment for this coalition of advocates who know who they're dealing with, what the priorities are, the communities are serving, to have the best possible environment to really make a difference. And that includes funding. You need to fund that. It's not just happening out of thin air. So we had an example from some countries that I think it was Pakistan, working across sectors and across stakeholders to really drive change for newborn deaths and see a reduction in deaths. And now that partnership, that advocacy partnership, is growing in power and influence because it's so successful. So there is a lot that's already happening from the organization who know the context and know the issues, and I can drive change. And I think that's the 2 main things, collaborate and really make sure that the power is where it's really is impactful.
Thank you, Benedict. You mentioned that there are these consultations happening in different regions of the world, and I imagine WHO and the 40 organizations in the coalition are kind of facilitating that happening. But what else can you share about the role of WHO in bringing these people together and bringing the community voices to the table? And what are some of the lessons, opportunities, and challenges that you see in doing that?
I think the consultation was not just this 3 events, and these are organized by the INAPPM group, but the coalition behind the strategy. If anything, WHO is not the organization to bring community together. This is not what WHO is good at. This is exactly where we should really rely on our partners and on the people who are already doing it, and not trying to fit a rule that is not the role of WHO, but rather in the spirit of collaboration, making this happen and facilitating it. It requires that we have a mechanism in places when we do advocacy, when we work at the subnational, national, regional, and global level, that everything is based around that strong national partnership centering CSOs. That is the whole point of this coalition, is to work toward this. And it sounds really basic, nearly. We need a partnership, we need a mechanism to make this happen. But when we consulted with the MNCH community, that's really what came out. We have these gaps, or we work in silos, or we work in parallel, or we have all this initiative. I think, Jackie, you said that there's so many initiatives already at country level. We work with the same actors. We want the same feedback. We can be absolutely overwhelming with question and mapping and question and more question and feedback and so on, and monitoring. So how do we make sure that we know which organizations are already doing the work, which coalitions are already very well positioned to do that? How can we ensure we support this rather than creating parallel track? The challenges you asked, Melanie, the challenges were very much about, I think, being realistic in what we can achieve. So in our PPMM, there's this 1990, 80 goals target that you mentioned, which are very broad. But because we have these 29 countries that have by themselves decided to accelerate the progress, to prioritize what they can do between now and 2030. The plans are 3 years, but they will, the plan is the plan of the plan. The bigger plan is to look to 2030. It's a very clear framework for action for advocate. It's a very short framework, but the whole point from an advocacy perspective is not to ask for new commitment, but really to deliver on the existing commitment. So this plan gives us an opportunity to have this very clear window of action at all the regional, global, and national levels to make things happen. When we know what the gaps are, when we know that these 5 points are the key points to see changes in the next 7 years, and we have the Minister of Health leading this. The very important point in making this happen is also that they work with a partnership or a working group at country level that represent different voices and different capacity, which is what is happening. So I think that the challenges was very much to be realistic in how much can you achieve in 7 years. These plans have a very good, a roadmap to what can happen. And the advocacy strategy around this is to support this. It's an advocacy strategy to try to support what the country already decided to do, obviously. So how can we have, and I saw that in the Mentimeter, some common guidelines or priority? How can we have some joint messages, which of course cannot apply to 29 countries, that's not the point, but can be adapted because this is what the countries say they want to prioritize. How can we make sure we really amplify those messages? How can we actually try to make sure there's funding to achieve this very specific objective and this very specific advocacy objective by 2030? So these are the challenges and what we're trying to do.
Thank you. As for opportunities, I heard joint messages.
Yes. So at the national level, the strategy at this point is very much a roadmap. There is no strategy that can tell any country what to do and shouldn't in any case. So not one, not 29, but a roadmap of, in your national plan, you've highlighted that the absolute top priorities for you is to mobilize more funds and use the funds you have better to decrease maternal and newborn deaths, for example. So with this in mind, this is a few things that we know have worked elsewhere and maybe it can work for you as well. But the whole point to make this happen in any of these 29 countries is that when they have this plan, this MNCH acceleration plan, many of which have advocacy asks and priority, that you have a coalition of national partners, advocacy partners, doing this and saying that the priority for us is, I don't know, let's say stillbirth reduction. So the priority for us will be to work with these stakeholders and to deliver this, and this is the plan for next year. So the strategy doesn't give a plan of action for any country, but really some broad guidelines on what are key possibilities to advance what I already said. And this should be led by national and subnational advocates, by CSO in a consortium, and supported by the other partner in the country, which means UN organization, a professional association, the private sector, donors, INGO, everybody who is working toward the same goal, supporting this work by national advocate. At global level, the strategy gives these global messages or these broad messages that can be adapted and completely changed as well, guidelines for implementation, and also mapping what the INA-PPMM partners are already doing and where they are. We also try to link with other area of work, so link with child health, looking at the multi-stakeholder platform that already exists, so to make sure we really make these linkages and don't reinvent the wheel. So yeah.
Thank you. And without really putting you much on the spot, but reflecting on the mentees, we heard
Yes.
from people, what do they need to galvanize this advocacy agenda? And we heard things like we need the evidence from from the subnational level to national and so forth. We need funding. Do you have any example that you can share of a particular country that comes to mind that has really excelled in their advocacy efforts? We heard even from Jackie that Uganda was able to mobilize domestic funding for MNCH, and they were seeing great improvements. But then the funding is now reducing, the efforts are becoming a little lower. So we have the experience from Uganda, but do you have lessons learned that you could share from countries that are really advancing on this agenda that others could learn from? How do we galvanize funding? How do we bring the evidence to the table?
Yes, so I think because we just had that meeting in Bangkok last week, and it was agent specific, but that's what comes to mind now. There was a very strong example of how that worked, and I mentioned Pakistan, which managed to bring together an advocacy coalition specifically to reduce newborn deaths, and they've done so successfully that they're now expanding and addressing other aspects of newborn deaths. So that is an excellent example of what that means, and they worked with governments at national and subnational levels. At district level, they worked with a whole array of stakeholders, which I think is amazing. There were other examples like this in other countries in that region. There are very many examples as well in Africa as well. So there's no lack of example of how that worked. But in terms of what is needed, funding for sure. You cannot keep saying we need to improve and then not deprioritize. When you deprioritize maternal newborn health, you deprioritize women as well. So we need to be consistent. The question is not whether it's still a priority. The question is how we pitch it into broader agenda, so we don't cut these women in bits according to what stage of their life they're in or to what condition they may have. But we really address the person and not an issue. So that is the point, to make it part of a bigger agenda. And a lot of the discussion are already about this. There is a lot of discussion about how climate change affects women's health, maternal health, newborn health, how gender equality is an absolute key portion of making this happen and making change happen. So yeah, it's more that thing. Yeah.
Thank you so much, Benedict. We've had very rich interventions from all our panelists. I really appreciate your sharing your challenges, your lessons learned, so that all of us can learn from it. We will transition to the question and answer session. So I ask all of you to our panelists to come on camera. I'll try and direct the questions that I can see at you. To all participants, please continue to use the Q&A. My colleagues are summarizing some of the questions for us here. And also, if you want to come off mute, please keep your hand raised, and then we will open your mic for you as well. So there's one, I think, very important comment that came through, not a question per se, but it says we need the political will because we are trying at our level. We're trying our best at our level, but you find that health facilities are missing some essential commodities. So without political will, it's very difficult to achieve change. So the question actually is, what efforts have you seen to successfully increase political will? And so maybe I'll turn it over to Angela, from your experience in Nairobi, perhaps. What can you share about what you've seen to increase political will?
I think, thank you so much. I'll try to speak slowly this time. I think they say that in advocacy, what we need to do is ensure that whatever we are doing changes the souls and the hearts of people. And until people do touch the hearts and souls of people as an advocate, it's very hard to change that person because people have heard about the numbers. People have heard about the data and all that things. So what we have seen work, and this is from the work that we've been doing across the country, is that once you are able to package the stories, once you are able to let the people tell their stories, bring the people together with the policymakers, with their midwives who are taking care of them, so that they can speak on their experiences. So that in either in town halls or in different spaces, whether in documentaries and barazas where you bring the people, whether through citizen journalism or community journalism where you showcase what the community, what is really happening in reality. When these are people, policymakers are people, and people have their own emotions and the like. So what I've seen is when you see women talking about with their duty bearers, with their midwives, together the same voice, where we bring the community together, we capture the stories, we come to the midwives, we listen to the midwives, with the communities listening to what midwives are going through, midwives listening to what communities are going through, and then together packaging and taking it to the policymakers. When they have a conversation, policymakers do act. But now there's another question that is, I was just typing a response that is around how then do the policymakers act? For example, when it comes to increasing funding, I will tell you, like a place like Kenya, it's almost like beating the drums to expecting the goats to dance. We are in a country which is so much in external debt. And the reality is this: I think the advocacy for MNCH has to move beyond communities pushing for advocacy at local level for the policymakers to act. To us, I think we need to divide roles, advocating for our external governments to reduce the debt burden, because now governments are pushing the money from what is meant for MNH to go and pay in debt. So as we are pushing policymakers, they can clearly say we can only allocate this. We want to, we can allocate, of course, not all of it. I'm not saying that it is wrong to do grassroots advocacy and all that. But the truth of the matter is most of the countries, and let me talk about the ones in this part of the world, they are dying in debt. How then do we also advocate that the debt burden is decreased or something happens at the end of the day, because we will just be doing almost something that we are not going to see results at the end of the day. But yes, advocacy works, and I've seen it work. I've seen facilities upgraded. I've seen policies changed. I've seen investments increased because of policymakers actually coming to terms, putting the shoes in the hands of, their own legs in the shoes of those women, in the shoes of the midwives, and investing. So it's all about how then do we advocate? Because for me, I believe advocacy is really a push in changing lives, in changing thought, mindset, and the like. Yeah. So I believe that at the end of the day, depending on because what people think is advocacy, for me, sometimes surprises me, because people think sometimes behavior change communication is advocacy. That is not advocacy. Awareness creation is not advocacy. When we talk about advocacy, it is a whole science in itself. It has a process. And then the other thing that I've seen that is going to help advocates is when you think about advocacy being a change process, it cannot happen in 1 year, in 2 years. But I've seen funding that is coming to support grassroots organizations for 6 months, for 1 year. Is it really realistic? Do we want to see change, or do we just want to tick a box that we have actually supported grassroots and community organizing? So at the end of the day, I believe it works. It is two-way. We have a role to play externally, but also internally. And all of us, it's our business. We just have to see how then do we change the souls, the hearts, and the minds of people to really act on women and their newborns. Thank you, and back to you.
Thank you, Angela. Advocacy is everyone's business. It is so true. Maybe I can ask Benedict this next question. How can technology and innovation be leveraged to improve MNCH outcomes? Do we have some specific technology and innovations in our regions that have helped in improving MNCH? Do we have a platform for sharing this information? Do you know of any such use of technology to advance advocacy?
Not specifically to, can you hear me? Yeah, not specifically to advance advocacy. I know of innovation to improve MNH and then using this as part of the advocacy. But no, I don't have a specific answer to this, and I don't want to blabber around.
Yeah.
The topic.
And maybe I'm reading it wrong as well, because it says technology innovation to be leveraged to improve MNCH outcomes. So not necessarily advocacy. Yes.
Yeah. So in terms, and this is also why working with the private sector is critical when, as advocate, to the capacity to support innovation and bring it to scale. I remember from a few years ago now working on that, on what are the new technologies that we can use to improve maternal and newborn health. And that went from everything to developing commodities that were appropriate for the context, so easy to stock, to transport, and to use in contexts where it might be remote, where there might be no refrigerator and so on. So that's one thing, and easy to keep for a while. There was a product which still exists, has been done since, to actually reduce postpartum hemorrhage and save the life of a woman. So all these are very key, and they become part of the commodity that we hope are being made available. The advocacy is really on how to make this commodity available. And I think one of the key things when we're looking at the gaps in progress for maternal and newborn death, so reducing maternal and newborn death, what that's, and we talk about quality of care, it's everything, is the quality of the health workforce. And I've seen a question about midwives. So the quality of the health workforce, the importance of qualified midwives, for example, and how much of a difference they can make during and after pregnancy, the access to the commodity, and not just to any commodity, but quality and quality control commodities, the access to properly equipped and functional health services and health facilities. So quality is everywhere, and innovation is one of these aspects that can really help doing this in terms of the commodity, but there's more than that. And I think when we do advocacy for proper services, for quality services, it can encompass everything. We cannot advocate in every point, everywhere, for everything, but it addresses all these issues so that women and newborn have the care they deserve.
Thank you, Benedict. And maybe a final question to Jackie. A participant wrote that I believe strongly on community driving the MNCH agenda, and we need to all drive for power to the people, but that community action also includes locally sourced funding. That is where the community truly has the power to influence their change without the influence of external priorities. I'm interested to hear what the panelists are doing in the area of locally sourced funding. You have lessons or experiences that you can share about sourcing funding locally?
Yeah, thank you so much. I'll start by contributing on the political will. I had a very interesting approach that we use in Uganda. In order to catch a thief, you need to befriend a thief. So for us, what we've done is to make sure that we make those political leaders our champions. For example, we have different members of parliament from different committees, not even related to maternal and child health, even the ones that represent the army, the ones that are on gender, and we bring them together as champions of maternal and child health, working with already existing forums and committees. And we've also had that model operate at subnational level, where we work with executive council, and we pick out like 80% of them who are interested, we train them, and they become champions. That means in a way we are converting them, just like my sister said, and getting them on our side. So by the time they're discussing anything on maternal and child health, we already have a good number of supporters with political will. So when the bill comes or any suggestion is tabled, they come from different corners, not necessarily the committee or the fora that is responsible for that. Back to locally sourced funds. I would seek to clarify later whether this means domestic or resources that come from the community other than the government domestic.
The latter, I think. If the community can source funding locally, then they have the power to influence their change without the influence of external priorities, is what's written. So do you have any such experiences of the communities coming together for MNH and influencing the decision-making at very local level?
Most of this has not the examples I have, but my colleagues from Uganda can add in case there are other examples. There are a number of them online. It's not necessarily maternal child health per se, but we have the community-based kind of community insurance, where a group of women come together, a group of community members come together, and they pool resources for health. And in a way, that same health basket funding that they put from their own income can help, for example, if a mother is not able to get transport to go to access maternal or child health services, or a child is sick, they might not be able to do bigger things like buying commodities that are very expensive, depending on the income of the community members who are part of that circle or part of that community-based insurance. But it is put particularly for health. But you know that issues of maternal and child health, in most cases, they come as an emergency. It's not like family planning. If you don't take a pill, you don't die. You suffer the consequences later. But if someone is in labor and they need to go to the hospital, that means immediately those are some of the resources they will touch to help the mother reach the hospital. So we have those kinds of arrangements of women, of community members, of churches, of friends coming together and putting resources for health. And that's because we don't have a national health insurance, and also our public service healthy facilities can be a challenge sometimes. Thank you.
Thank you so much, Jackie. We will not be able to answer more questions, but there are a few important comments that have come through that I would like to just highlight. Dr. Jemima Arabadenis Antiri wrote that one other major issue that needs to be addressed by advocacy is the issue of the centrality of the midwife to addressing the MNCH challenges. The evidence has shown that where there is a competent and regulated midwife, over 80% of obstetric complications can be addressed. So we need to center the midwife in our advocacy agenda, put our political leaders in the shoes of our midwives as well. So let's center the midwives in our advocacy efforts. We also heard from Patrick Ujulong, who said the reality is the physical space is becoming limited for additional resources for MNCH. I think we need a new approach, identifying wasteful areas in other sectors or agencies of government and showing policymakers such areas as resource saving, resource generation for relocations toward MNCH. The other area that I have drawn lessons from is RBF, results-based financing for MNCH, and the turnaround of some indicators. I think we should advocate for such models for specifically MNCH. So we have various needs and scarce resources. So how do we move them from where maybe they're not being used fully or to the results that we want to see and reallocate them to those that could really save lives and build human capital. We also heard from Opio Polycarps, who said we need to build the capacity of the local communities for them to have informed and meaningful engagement with both the stakeholders and government agents to prioritize funding for MNH interventions. We also need to mainstream social accountability, as our previous panelists said, in MNH programming. So thank you so much for all your comments on the chat, all your questions. I'm sorry we don't have time to answer more of those. So I'd like to transition us to Menti again. And while we pull that up and you all log back in with your codes, or if you've not closed it, you can access it again. I just wanted to highlight a few of the things that our panelists said. Collaboration. Let's stop competing for resources when we have the same agendas. And as I read these comments, please add your thoughts to these key advocacy moments and opportunities to elevate MNCH advocacy in 2024. Here's the code up top for you to use on menti.com. I think even Bernadette had started talking about, Bernadette, or I think Jackie had started talking about a few of the events that are happening this year that we should really leverage. So please add to the thinking there. So collaboration and stopping competition, thinking beyond the MNH in the health sector. So other health areas that contribute to the MNH agenda, like reproductive health, and beyond the health sector as well, because MNCH is a multi-sectoral effort. It's not the health sector alone that's going to change so many of the social determinants that are beyond maternal and neonatal deaths. Localization. We need to bring the people that are experiencing these challenges up front so that they too can contribute to developing the actions and the strategies for accelerating progress. So centering the work on civil society organizations that can bring the voices of the mothers, that can bring the voices of the communities, bring the voices of the midwives, and think of a whole system approach. We need more social accountability. We need to hold decision makers accountable. And there are a number of interventions that our panelists talked about, community journalism, and so many other opportunities that we have to bring the voices of the communities and also hold our decision makers accountable. We know what needs to happen, so we need to invest what's going to bring the most rapid progress, including investing in quality of care. And those are just some of the reflections that I have from our panelists. And I'm hearing you all talking about the World Health Assembly on Menti, a resolution the resolution on MNCH is a key moment for this advocacy. The AU summit that has passed, what's the plan for something next year? Maybe we've missed some opportunities this year already that we want to think ahead for next year. The investors group meeting in June and November, where the CSOs will have an opportunity to bring a joint statement. CFIA that happened earlier this year. How can we take the resolution back to our countries to hold leaders accountable? So coming from last year's conference, how do we then bring momentum to everything we agreed in the conference last year and hold our leaders accountable? You've also added the World Health Assembly, UNGA, the UN CSO conference in Nairobi, the World Health Summit, Summit of the Future. All of these are opportunities which we're taking notes and continue to elevate opportunities for us to collaborate to elevate the MNH agenda. Thank you so much. Please feel free to continue to add your thoughts here. And I am going to now close the session and hand it over to my colleague, Esther Nasiki, to give her closing remarks and wrap up the session and share what some of the next steps are. Esther, over to you. Thank you so much.
Thank you so much, Melanie, for wonderfully moderating today's session. We really appreciate that. Thank you so much to our speakers. Thank you, Jackie, Katana, Angela Ngoku, and Walter Benedict. Thank you so much for sharing your insights, your thoughts in terms of how we can connect our advocacy right from the grassroots level, right from the community level to the national level, and to the region and the global level. If I could share my quick takeaways, I could summarize it in terms of the 4 C's and the F. Please keep adding, but mine are just 4 C's and F, and I will talk about community. I think, making sure that the grassroots and the community voices are amplified, they are listened to, and they have, the support they need. That is important. But then also the whole issue around coordination for the advocates, but also coordination in terms of the work that we are doing at various levels is important. I'll talk about collaboration as well, so that it's just not one entity, because we need to put aside the logos and the egos, because the issue is bigger than all of us, so we need to collaborate. And then we talk about capacity. capacity remains important. The capacity for the advocate to be able to articulate and present these issues, to the decision makers for decision, but also capacity of the community, members themselves to be able to amplify their voices and speak to the decision makers themselves. So we talk about capacity at various levels. And then, of course, the issues around financing, that political will needs to translate into financing, but also, financing for the movements, financing for the grassroots engagement processes is still important. Those are my quick takeaways from this first session. So thank you so much for sharing your insights with us, our speakers. In terms of our next steps, again, like we said, this is going to be a quarterly space where advocates come together to learn, to share, but also to work towards, a joint vision to advance this advocacy. So our next session will be coming up in June 2024. And ahead of that meeting, we'll have the opportunity to engage with you to say, what is it that you want to use this space for? If you are talking about capacity building in what area, or capacity enhancement in what area, so that as an advocate, you are empowered and confident enough to move the agenda. But also thinking through some of the opportunities that you have shared with us, maybe it will be an opportunity to come together and think through what strategies we need to advance during certain moments. We know that will be after the WHA, but there will be other moments that are coming up. So we do appreciate you all for joining us. I know we don't have a lot of time, but we do appreciate you all for joining us. And please, let us keep the momentum going as advocates. Let us contribute to the conversations and keep working hard right from the grassroots level, at the national level, but even at the region and the global level as well. I have my email address right there in case you want to raise. There was a question that was not responded to. Please feel free to raise it with us. I will make sure that we remain connected and you receive the responses that you need. But also, as we prepare for the upcoming session, please, let's remain connected and let's keep, talking virtually as we utilize technology, but also through other mechanisms. So with that, thank you so much for joining us today, and we wish you a happy rest of your day. So thank you so much, and bye. You even have 2 minutes of your time back. So thank you so much for joining us. We'll see you in June. Bye.